Hello, ladies and gentlemen. We'd like to welcome you at yet another session at our symposium. I'm really happy that the room here is full. Now we are going to discuss medical devices. This will be a continuation of a discussion about the efficiency of the system. I would like to propose, and this is a question to do we have Elena's recording? Unfortunately, Elena informed us that she has come across some issues and she will send a recording, but not now. If we don't have it in time, we will upload this recording on our website. We are waiting for the last speaker. The next session, I'm really happy we have two guests in our studio. Now we will be talking about medical devices, but about healthcare services in general, access to non-drug technologies, and in this regard we have two guests. Ewa Warmińska-Friberg, who will be presenting the perspective of the industry, of the marketing authorization holder, but also a representative of the decision maker, that is of the Ministry of Health. He will be kicking off our session and we'll have a look at the perspective of the Ministry of Health. Thank you for having me. It's a pleasure to be here with you at your conference. It is a very pertinent topic, as already mentioned, touching upon medical devices, but I will start with discussing general issues regarding the healthcare system and what conclusions are drawn by the Ministry of Health based on the data that we are collecting, mostly financial data, but not only. What actions are taken resulting from two issues. One thing is conclusions based on some strategic decisions, and one thing that speeds up certain actions, that is the National Resilience Plan, Recovery and Resilience Plan. Because those funds decide on whether we meet the milestones. Those milestones involve various reforms. And those reforms are quite broad. One of them provides for the introduction of the National Cancer Network and some milestones regarding the implementation of those aspects. And as part of the milestones, we also have a project which has been quite well discussed, that is the inverse health service pyramid. So we have many things that are intended to improve the efficiency of the healthcare system. That was enshrined in a way in the National Recovery and Resilience Plan. This is a mobilization for us, a motivation to act within specific deadlines, because we have some specific timelines. So it's all hands on deck at our ministry to make sure that it happens. Yesterday we had a longer discussion, after which I thought that my presentation might need some adjustment. So moving on from the more general data, let me start by telling about where we invest, how the financial situation has changed. It has been widely discussed recently because when it comes to the National Health Fund budget for 2024, there have been problems. For the next year, the outlooks are also not particularly optimistic in this regard. But since 2018 until 2024, the public system was additionally received over 100 billion Polish zloty. The problem is that the majority of that amount was spent on increased wages. not on medical treatment. The vast majority, 69%, is the increase of wages of healthcare professionals, and only 31% of that amount was spent on additional health services. This is one thing, the one thing that is quite disturbing. Another thing is that quite a lot of the money that is spent on the healthcare system, the allocation is quite questionable. So it's about buying more, buying better, for the in exchange for the resources that we have at our disposal. However, 50% of the entire allocation on health services, which is 159 billion Polish zloty. I'm not talking about reimbursement, it's the other health costs. Around 50% of that amount is spent on inpatient treatment. And this is one of the main problems, because it is associated with inefficiency. Because if we have a look at health systems in Western countries, this proportion is different, it's lower. In Western Europe countries, the amount of money spent on healthcare, specifically on inpatient care, it's between 30 and 35%. So we spend much more on inpatient care than Western countries, and outpatient services suffer. So the distribution is in outpatient secondary care is different, and of that 159 billion, only 10% is spent on that. Not to mention the issues of primary healthcare. Around 11% is spent on primary healthcare. Here, coordinated care, which has been introduced recently, has changed those proportions a bit. I can see there's a slight delay with the slide shifting. On the one hand, we do have significant funds, but on the other hand, the way that the money is spent is not as effective as it could be, based on the example of Western European countries. But still, it's still less money spent on healthcare than in the case of Western Europe. Why am I using this data? So this increasing of spending on healthcare is anticipated to be increased year by year. The budget on healthcare will be on the rise. But before we reach the European level, we need to carry out actions which will increase the efficiency of the existing funds, because if we don't, we will continue to make the same mistakes. Currently, outpatient secondary care is struggling. The waiting time for specialist care is not being, the waiting times remains high. Small local hospitals are tackling financial problems, and larger hospitals generate profits and have a good situation. We can see that something's not working in the allocation of public funds. Most of all, this all affects general availability of healthcare and its general quality and the patient's comfort within the system. Of the three things that will be happening soon and which are related to optimization of the system and increasing of its efficiency, it's coordination. It's a frequently mentioned word. Coordinated care first came up in the subjects of transplantology and cancer care. Then on the example of Dutch and Danish programs, we introduced some pilot programs, and coordinated care in various areas is developing. More and more primary health care facilities have signed contracts to carry out coordinated care. What is happening is the fact that we have the introduction of various coordinated programs like the National Cancer Strategy. So a pathway of the patient has been introduced. Specific stages of diagnostics and treatment have been indicated. They are indicated as necessary to guarantee the relevant care and its continuity. So that's the one aspect of coordination. Soon, the act on the National Cancer Coordination System will be introduced as well. I think that in the future, similar solutions will be introduced for neurology. So again, coordination is key so that we do not have unnecessary repetition of services, which has a negative impact on various actors of the healthcare system and which unnecessarily extends the waiting time for care. The second project is the inverted pyramid of health services. Currently, this project is at the analytics stage, but everything is carried out in such a way that this inverted pyramid is introduced. So specialist care services are supported, are strengthened, so that in the future some services are moved from inpatient care to outpatient care, so that hospitals do not deal with diagnostics. Diagnostics should be the area of outpatient care. Those procedures are much more expensive when carried out in inpatient settings. The burden for the system is greater, and this also results in an inoptimal use of the existing infrastructure. A third point, which has already concluded public consultations, that's a program regarding the reform of the hospital system. Hospitals will have more freedom in adjusting to the needs of the society in their region. So the focus will not be on the well-tariffed services, but hospitals will be incentivized to adjust the scope of services provided to the local needs. This program will allow for such incentives. So potentially the costs, the unnecessary spending on inpatient care will be changed. This will involve processes of consolidating and changing the structure of hospitals, because there are more and more hospitals where 110% of the hospital's revenues is spent on wages alone. There are more and more hospitals like this. So hospitals are becoming indebted just to pay the wages of the personnel. And additionally, there are other costs. So the debt increases, it spirals. I'm sure there are more needs like that. Yesterday we talked about medical devices, about the approach to policy. It's simply, we don't have a policy like that with regard to medical devices, but I guess Magdalena will be talking about this. I would like to thank you for your attention.
I'd spend the whole session on these topics, but because we have 3 presentations, let us move. I think this is a good introduction, especially that each of us has a different perspective. I would like to present you the launch of new technologies. You talked about the structure, the flows, and the types of treatment, large-scale reforms, indeed, and the improvement of tarification as well. First, it's about defining the structure, then it's about maintaining the structure. And we have a transition period ahead that we need to contribute a lot in order to have something that we want. I see another factor of efficiency. If you launch the medical device, it's a broad category that you touch upon. Diagnosis, every single item used for patient. All types of devices need to undergo notifications, a CE label mark is needed, and you have class 1 where you have the wheelchair, stethoscope, walker, all of that. Then class 2A with an increased level of safety and a more specialized care. Simple devices will not be used if you need to transplant something. So as you can see, there are a lot of challenges. And it's about the speed of innovation in our services. Apart from that, you have in vitro devices used mainly for a broad diagnostic, and here you have 4 classes, so MDRs and IVDRs. The diagnostic is a piece of and parcel of the outpatient clinic. So every service will cover a variety of medical devices provided to the patient as a package. I think that we need to take into consideration a number of elements. First, the Ministry of Health and the decision makers would decide what will be in the package. Then healthcare professionals will use state-of-the-art technologies, guidelines, procedures, standards, solutions in the system, indicators in the system, accreditation, and the act on quality. Once the patient comes in until his path ends, we need to rely on a number of mechanisms, and they are not always consistent. Moreover, the services are made available at different levels. First, you have the guaranteed package, then you have the co-financed package, and the investment process. The investment process. This is something that is happening in Poland. For instance, in cardiology, coronography is no longer used in different countries, and instead of you use the multi-organ CTs. We still have some older mechanisms without any changes, simply because the budget is still there. We have a representative of Spain with us, and Spain realized that the investment needs to be done in order to avoid money waste. So, does the system react quickly to the changes around? So I will try to show if we are quick or not. Let me start with the medical devices in the Polish healthcare system. As you can see here, we have medical devices provided on request. If we compare Poland and Europe, we have a relatively good place. We are extremely flexible. It's true, new technologies are, and the uptake of new technologies is slow, quite slow, but still we are flexible, and we include some medical devices on the request of the patients. Don't forget that there are inequalities in access to information, and my recent study showed that patients are fully unaware of their rights, and the healthcare professionals are not always advised about the rights of the patient. So inequality in access to information. That would be the first group. Second, the list of reimbursed drugs. I don't think that medical devices should be reimbursed. Well, requirements are very restrictive here, but just compare drugs and medical devices. There are procedural inequalities here, and the Reimbursement Act was introduced in 2012, and nothing has been changed. With the third group, you have the guaranteed package. Psychiatry, primary care, rehabilitation, palliative care, well, different types of packages. ACD9 was used to define them. And actually, we got the co-financing from the National Health Fund. In the tariffication, you have the scope of medical devices to be used, the scope of diagnostic tests and other devices. This scope of services is defined not by law, but by the National Health Fund, and that is why it is subject to changes. And because there are changes and there is a very poor follow-up in the system, we have gaps. The National Health Fund reporting system is not enough, and we actually feed only the basic data to settle the services, and I do hope that the digitization will help. For a moment, we have real difficulty in monitoring what has changed in the system and what has been used and made available. What are the challenges regarding medical devices in Poland? But basically, we are in a delay. Individual hospitals or clinics are ahead in terms of innovative technologies. But on average, in the systems, the delays are significant, and such delays are caused by the shortages of staff, and sometimes the flow top-down is not always speedy. The system does not foster the flow of innovations top-down. Moreover, we fail to build adequate standards or recommendations. It's true, scientific societies would develop such standards, but they are not widely accepted. In 2017, the Society of Oncology could provide guidelines to be used nationally. And right now, we will have the first nationwide guidelines on oncology, and that's the only case. That's why there is plenty of uncertainty, and especially if something is new or time-consuming, or when you need to remodel completely the concept of treatment. Oncology is already there. For cardiology, well, we will probably have this set of recommendations. What's next? What are our plans? Third challenge, unclear rules of access to patients. Patients don't know what is offered in primary health care, in the outpatient hospital care, where the reforms are underway and the communication will be organized on that topic. However, this good communication requires the improvement in the quality of care. It's true, we need to change the structure, we need to change the form, but also the quality, the accreditation, the certification, and so on and so forth. We need to be clear, we need to define what is missing, and I think we have this mentality problem. We are unable to say what goes wrong, still painting the grass in green. We'll just be honest with ourselves. Standards are not always kept. We need repair, we need reform. I prefer to be honest with myself than at some point discover that everything went wrong. There is little investment in technologies, and it's top-down. The Recovery and Resilience Plan provides some funding, but we don't have local plans. It's not operationalized. We have a strategy until 2030, but it's too general to become really operational and to give us this assurance that we really react and respond to the needs at hand. We forget that there is this disinvestment process underway, and I think we fail to recognize that. We can talk about with our Spanish colleagues about the process, but basically it's the question of reactivity, and here the decision makers are a key role to play, and change management should go top down, not the other way around. Just have a look what is our position in terms of innovation in healthcare. According to the WHO data, we fall behind. Just have a look at the last digitization compass. We are not that bad because we have a quite good e-health access, and we are leaders. We've had a leap in that respect thanks to the Recovery and Resilience Plan. But in terms of operationalization and the uptake of innovation, it's not that optimistic. So we speed up digitization, but we do not use it to its full potential. We are not always precise. Sometimes we introduce medical devices without knowing what we introduce. 5 to 10% is introduced through the central system, and actually it has been dramatically damaged by COVID, and some items are simply introduced without proper assessment under the pressure of time imposed by COVID. We did it for the first time, and well, there are other countries like Spain or France or Italy. They have hospital bed data just to have some leaders in the system to improve efficiency and to improve cost effectiveness. We have no pilot projects that could be of use. Our guaranteed package is not satisfactory. And if you look at the statistics, There are 13 devices assessed by the HTA agency per year. That's one per month. Well, it's slow. Believe me, it's slow. Moreover, because the system is underfinanced, we have one of the lowest rates for laboratory tests, and so we are underdiagnosed. And only the coordinated care once introduced showed that we need coordination and we need standards to improve the mortality rate and to improve the health outcomes. Digitization. Digital tools. Well, for digital tools of e-health, we are quite good, but the uptake of innovation, it's really poor, and we have an untapped potential. But generally, EU struggles with innovations. We are late, but the EU as such is much behind the US, Canada, so this is an issue. And Poland, I think this is a sort of a mentality problem. Probably the reaction times are long. This is an issue to debate. Just have a look. Poland is one of the leaders in terms of digitization and in terms of e-health data and access, public access of patients to data, and I think that we should do our best to keep this trend upwards. And now HTA for medical devices. Availability, usability, effectiveness, practical requirements, sort of a path, the flow, cost effectiveness. That's not always the case, but sometimes this is the criterion. You can improve efficiency without having a cost effectiveness. And then the impact on the budget. So these are the key criteria used in the HTA. So we failed to introduce a system to measure the impact of our decisions. I mean, to check whether what we assessed initially, like availability or usefulness or effectiveness, have actually improved. So the change effects, the changed outcomes should also be measured. And for that we need proper system features. The German system is a case in point. Here the tariffication is based on the automatic flow of data. There will be no separate plans, no separate statistics done manually. No, everything is automatic. Although it would take like 20 years. Just use digitization, use the automated collection of data, and we actually spend a lot of money on digitization. The tools are there, but there is no system. Germans would do it once a year based on automatic collection of data. Cost accounting standard is not enough. Cost accounting standard would just give you the frame, but without the details. The HTA agency is ready, I think, to make this leap. I should show you the next slide, which is about procurement. We have a post-containment system. I travel the world and everyone asks me, you have so low cost system and you still are able to ensure the right procurement. Well, we are masters of management, but we are not good in improving our efficiency. We prefer financing something more expensive because this will give benefits outside hospital. Or the other way around, we can use the outpatient clinics and use that something expensive to reduce costs in hospitals. And in PCT study, you see how the preventative care in sepsis in the outpatient clinic will help to reduce patient costs. For that, we need guidelines and we need recommendations. But we already have some mechanisms to make such assessments. In 2017, we had a document published on the usability of HTA where the HTA showing the usefulness of some solutions. But actually the assessment is being done, but what is missing is the reaction time, or actually the strategic discussion on our reaction time and strategic decision making. It's just one pattern of action lasting for 2-3 years with no quick wins along the way. Maybe we need a mentality shift. The majority of countries, with Australians as the first one, wanted a rapid review. And today we have AI helping us to do systematic reviews. And last year, Australians said that they were able to do the rapid review within 2 or 3 months to answer some very relevant questions. So again, just use the AI embedded solutions. Maybe new skills should be added at the HTA agency. What are the solutions available across the globe? Well, for medical devices, the assessment is quite rapid and nice. Is a case in point. The UK here is a leader in new solutions, plus Spain, which has chosen a hospital-based system. So let's think whether the National Recovery and Resilience Fund shouldn't be used to introduce monitoring centers. Centers of excellence and the first single point of assessment. A rapid assessment to tell everyone, is it worth or not worth doing or implementing. HTA. Well, I think that we need a redefinition. It's not the report only. What the world needs now is rapid assessment, evidence gathering, quick assessment, RCMC, the digital centers to collect data. Maybe there should be again a mentality shift for the new centralized and strategic thinking. Response time, that would be another need. We need to respond quickly, and I think that was the beauty of the pandemic. Agency was able to reply in 2 or 3 months. That should be probably the norm and not the emergency measure. And some key questions need to be asked to implement or not to implement. And for that, I think we can use pilot project, POS Plus, POS Plus or others could be used here. After 4 or 5 years, we can say what went wrong and what was successful in our pilot project. Maybe the decision-making process based on pilot projects should change as well. Is it the model we want for the future? I don't know, but that would be my conclusion. Are we monitoring, do we ensure a follow-up of what we've just implemented? Well, we don't. And the National Health Fund fails to collect the relevant data. I do hope that the changes in the system and the electronic health records will help. The obligation exists for 2 years, but some facilities and hospitals are not ready. They're still written and digital. Hospitals, for instance, do not have enough money to buy screens, to buy hardware, the very basic items. So just be honest. Just catch up. We still do not have adequate hardware base. Without that, we will not be able to implement any advanced technologies. I've just seen the type of hardware hospitals use, and there is one workstation and one computer PC and 3 people assigned to such one PC, or there are no computers at all. So just the technological debt which should be paid. And for now, the data from 2019 and the drug and non-drug programs, the ministry should propose the key items to be implemented. However, it has changed. The producers, the manufacturers, the medical societies should propose the items. And our legislation is actually not adapted. We have no timelines, we have no specific procedures, so we wait. 10 years, that was the longest period I waited to get a recommendation for a specific medical device. We need some different reaction times from 2 to 3 months to 2 years, depending on the case at hand, and JCA, Joint Clinical Assessment. We see that medical devices 2B3 will be covered at the EU level, and the rapid review and approval path is being built at the EU level. And some things will happen at the EU level and we will be behind again, and that will be again a question of adaptation. That will be all from me. I know that I asked too many questions and give too few answers, but that was just a food for thought. Thank you.
It's time for Eva now. Hello, ladies and gentlemen. I promised to Magda that my presentation would include everything she said, but that I will be doing it in an inverse order, but or that I will counteract what she said. But no, I actually agree with most of what she said. I will say similar things to what Magda said, but from a different perspective, from the perspective of companies. Because I represent Technomed, which brings together entities active on the market of medical device manufacturers. And on an everyday basis, I hear what challenges they are facing, what problems they have, and what solutions they have implemented. This is something what I'm going to tell you about. So this is similar to what Konrad and Magda already said, but from a completely different perspective, which is quite important because it helps us assess how we can change the state of play. Let's start with what efficiency of healthcare system is from the perspective of medical devices. How can they impact the efficiency of systems? As already mentioned, medical devices are products which significantly affect the entire process of caring over patients at every stage of the process, starting with diagnostic, through rehabilitation, and later on devices which help patients in their everyday lives. A good selection, efficient selection of devices that we can use in care of patients can affect both the efficiency of treatment, so improve its quality, can improve the efficiency of spending, because as already mentioned, there are a lot of devices available on the market. Currently, a lot of them are in a private system. They are available on the market, but they are not financed from public funds. And that could improve the quality of care. The use of devices can affect the duration of a hospital stay. It can reduce the diagnostic process. And as Magda already mentioned, there are many diagnostic processes, but at every stage, the right selection of the right medical device or a service which encompasses a medical device can impact the efficiency of the healthcare system. How do we understand efficiency of treatment? Because this is of key importance for the entire system. Improving diagnostics. If we have good devices at our disposal, diagnostics will be better. If it's a more targeted, more personalized type of diagnostics, we are able to start treatment sooner, which will reduce the costs, and the quality of life of that patient will be better. Medical devices also allow us to provide personalized, tailor-made care of the patient. The patient's rehabilitation can be supported. We can monitor the patient's health. We don't have many such solutions yet, but please keep in mind that this is already available. The patient does not need to go to a doctor every fortnight because there are ways to monitor the patient's condition remotely. This de-burdens doctors and also is convenient for the patient because it saves them the trip. If there is a follow-up visit every 2 weeks or every month, these are often people with from remote areas or with compromised mobility. This is a big burden for their everyday lives. Medical devices also reduce the number of hospital stays because with better quality of care, hospitalization can be shorter. If we introduce more cutting-edge solutions, then the surgery or the whole service using modern technologies can reduce the time of the hospitalization. It can result in a situation that the surgery is less invasive. We again deburden the patient and the system. The system is deburdened because the patient no longer requires care, and obviously there are other indirect social costs that are also reduced. What else do modern solutions offer? By saying modern solutions, I don't always mean innovations. Magda mentioned that we have different types of medical devices. By innovations, I mean things which are not covered in the guaranteed health services package. It's not always things that are the latest things, but things that are not reimbursed in Poland. We have AI, which supports a lot of processes, and this is something we should be focusing on, but there are also many other solutions which can also significantly impact the process of care of a patient. They might not be very innovative, but we still don't have it guaranteed in our Polish system. So what can support the whole process is, for example, the manner of managing resources, both human resources and other resources. What Magda mentioned, lack of electronic health records, lack of communication between different facilities, which requires the need to repeat tests which already have been done. Each new healthcare provider needs to do some aspects anew, for example, collect new data or reanalyze data. It all extends the process of caring of a patient and could not be necessary. Electronic health records is nothing new, but it's still not a standard thing in Poland. Telemedicine, remote monitoring, again, it's the same thing. There are some solutions that allow, for example, to collect data from different devices on a tablet. It wouldn't be necessary to go from bed to bed in a hospital to see how the patient is doing. This could be done remotely, provided that there is support from other medical staff. So we're not talking about higher systemic costs, we are talking about greater efficiency of the existing resources. And now the question which was asked by Magda, why is this the case? The ministry representative said that we are working on an improvement of the situation. But the question is, since I'm saying that it all seems to be so simple, why isn't it already in place? Well, actually, it's not that simple. I know this because I work with the companies on a regular basis who see those solutions, who work on a daily basis with doctors, with healthcare facilities, who every day work on analyzing which solutions are reasonable, which bring good results. I have access to them and therefore I know what can deburden the systems, improve the care of the patient. The question is whether the Ministry of Health is actually aware what solutions are available, which are in the system, maybe outside the public system. And if they don't know that, how can they change that? How can they learn about that? Is there a pathway where they can get that knowledge? As a representative of marketing authorization holders, manufacturers, I can walk around and talk about it. In the Ministry of Health, we have five ministers and 6 departments. I could be meeting each of them. I can tell them about the solution. They will send me to a different vice minister. Then I will add something more. I will repeat. Then they will send me off to a 3rd person in the ministry. They will consider it. They will not be really making any decisions. There's no one to talk to, really. It's because I'm starting from the position of a medical device which can be included in the service. However, it's not the right order. If we diagnose the patient, we know what disease is the case, whether it should be dealt with inpatient or outpatient. The Ministry of Health doesn't really know the solutions which could possibly be used in this situation. So we could have a general health services package. Introducing changes to the package is very difficult. There is no pathway really, no platform where such solutions, such ideas could be presented. Why is that? This results from one more thing. A lot has already been said today and yesterday that drug technologies have specific pathways. It's very specified. Drug manufacturers meet in the ministry, and the ministry decides whether reimbursement should be granted or not. There's a bulk of data which indicates the innovativeness, the need to introduce this. This is not so easy with non-drug technologies. There are many reasons for that. Most of all, medical devices are really complex. I don't want to say that drugs are not innovative or it's not difficult to create them, but once you do have the product, the administration usually is quite easy. With non-drug technologies, there is a long learning curve for both the healthcare professionals who are to use them and also a long learning curve for patients. Adding such non-drug technologies to the package is also not easy because there are some other elements that are necessary to be provided so that a device can actually be used. With medical devices, it is also far more difficult to present analysis and data which would support the application. The awareness is also much lower. Awareness of how the decision makers should look at the device. What's also quite pertinent is that the devices are updated very frequently. There are new versions launched all the time. So with a medical device, it's innovative for a moment, and after 3 years, it's no longer innovative. It might not even get the chance to enter reimbursement, and it's no longer innovative. Something that was assessed 10 years ago no longer is innovative, and the guaranteed health services package simply doesn't keep up. How are non-drug technologies financed? So we have the guaranteed services package, we have pilot programs, we have health policy programs, we have a list of drugs, nutritional foodstuffs and medical devices. Let me focus on the second and third points that I've mentioned. So Magda already mentioned the guaranteed health services package. This seems to be a simple pathway because we have a regulation which regulates that. So let's say a manufacturer approaches the Ministry of Health. The Ministry of Health orders that the agency assesses this. Then we have a decision of the agency, and then the Ministry of Health takes a decision. It seems to be simple, but for the Ministry of Health to receive an application, that's not so easy. We do not have sufficient national or local consultants. There are many, let's say 1,000 or at least a few hundred of marketing authorization holders who want to submit an application. There is no defined structure of an application, no requirements which would allow for a positive assessment. There is no standardized pathway for non-drug technology applications. So now, the Minister of Health receives an application. He can send it to the Polish HTA agency, but they can also just file it into a drawer. An application like that just is kept in a drawer. I can try to look for an update. I can see whether the Minister of Health will, when we can expect an answer. Then I get a response that, oh, it is pending. Then after some time, after a few years, the agency gets the order. Then they get 4 years to assess that. And after 10 years, it's a negative decision. So there are no sufficient time slots. There are no time constraints on the authorities. We don't know what the policy of the Ministry of Health is. We don't know where they, what are their priorities. We ourselves see solutions which could be efficient for the system without creating additional costs, which already should have been introduced. We can't introduce them. What about more complex solutions, for example, AI-based solutions, which obviously is associated with various problems? I don't know if you know, but starting January 2025, we are supposed to have a new medical ethics code, in line with which the doctor should inform the patient if a service is to be provided based on an AI-based solution. All medical devices just support the doctor. They do not replace the doctor, but they don't have a decisive factor. They streamline the doctor's work, but they do not replace the doctor. Everything that the AI supports the doctor in needs to be confirmed by the doctor. So saying that your treatment will be based on AI, people maybe could think that it is simply taken over by AI and complain to AI if something goes wrong. But it's not what this is about. Patients should be made aware of the fact that modern technologies is something which facilitates their treatment. So there is no way to have a specified route of applying. There are no time restrictions for the authorities, and we don't know what the priorities of the ministry is, and we don't have real-world evidence data. And this is something which could be used in pilot programs. Pilot programs are also a difficult challenge because some of them will be implemented, some will not. Pilot programs tend to be better and better. They are more actionable and they provide us with more actionable information. The manufacturers don't really know which direction they should take because they are not being informed. Sometimes they come with really good ideas and they ask me, what should we do? Should we try to implement this in Poland or should we go abroad because the systems abroad are easier? It cannot be the case that we forget about something which is that important, that is modern technologies. Our healthcare system will not be able to manage without modern technologies. If we have a shortage of doctors, we have to support them. Even if we have more money on doctors, we won't just come up with new doctors. We have to find solutions which will help optimize existing processes and existing resources. Health policy programs have already been discussed at length, so I won't be focusing on it. It is a possible pathway that could be used for diagnostics or for rehabilitation or telecare of patients. What we have been noticing and what definitely should be highlighted is the need to determine a pathway for applying for reimbursement for non-drug technologies. Something which is frequently mentioned in discussion is the need for a possibility to apply to the Polish HTA agency that it accepts the order to assess a technology even for money, for a remuneration. So the agency could suggest some solutions to the marketing authorization holder of non-drug technologies. It could present it with priorities. Currently, only the Minister of Health can request the Polish HTA agency to carry out an analysis of non-drug technologies. In our opinion, it should also be possible to request, so a private company should also be able to request such an assessment. Various electronic databases, for example, electronic databases of disability certificates, the entire system is based on hard copies. There is no electronic system. Telemonitoring, telerehabilitation, telecare, this should be a new standard, and it's not the case. There are so many well-designed, available solutions. This should be the standard of care. But in this area, we are going slowly, step by step, and this should be implemented because this not only reduces the cost for the system, it also de-burdens the doctors. And we know that they are overburdened. We also don't have integration of health records. Because there is no consistent common policy, and for that we require changes to the provisions of law. We should have provisions that would regulate the way that the data is aggregated. It is inconsistent. So collecting data and analyzing it on one device can be difficult. Not to mention that the data should be consistent with data collected by the National Health Fund, by all different health facilities, because if the data is consistent, then we can carry out analyses that would show us what is actually happening in our systems. With the current way of collecting data, such analysis is impossible. We do have the data, but it is messy. We should introduce regulations that would allow for the use of AI. AI is everywhere. It is ubiquitous. It's being discussed all the time. It's necessary to regulate those issues. EU will be regulating that. In Poland, we are also talking about that, but we have to be cautious not to over-regulate, because if we over-regulated, if we impose too rigid frameworks on introducing AI in healthcare, then it will be impossible to actually use those technologies, and that would be a waste. And as I've already mentioned, we've got the question of expanding pilot programs or using ways to basically teach decision makers, those actors who are supposed to have a bird's eye view on the system, how to carry out a horizon scanning exercise, how to use existing possibilities, because we ourselves don't really know what the Minister of Health wants to achieve. Sometimes the information that we get is too general, and we have solutions that could be really helpful, but we have no way to present them. Thank you.
Well, I thought that I was smart and to talk for a short time and to be brief. If I had spoken longer, I wouldn't have time right now. You've said a lot, And actually things are underway because the philosophy has changed. The philosophy and the approach to systemic changes. Right now we are taking a field-based and area-based approach. In oncology, for instance, we have data collection and follow-up. Everything will be done through e-DILO card, the card that follows the patient. So it will just act like a magnet. So you have scattered pieces of metal, and the DILO card will act like a magnet, taking all the data together. It's about diagnosis, treatment, and a follow-up. And with the DILO card, we will be able to see how effective the process is. Without the tool like that, we are not able to answer such questions. The same solution will be applied in the National Cardiology network. We will have a sort of a card that will act as a magnet and will collect and gather all scattered pieces of data. Now the guaranteed services package. Innovation is a buzzword today. We are extremely late in terms of novel technologies. We don't have resources, time, and space to implement innovations. We simply have to catch up. The modernization of the guaranteed services package is a step-by-step process. It's not, and it should be continuous. Depending on the budget, the strategy was to either get into the reform or withdraw from the reform. The Ministry of Health, in the chart we have today, you know, it's like the speaker's button. I think that the Ministry of Health should not be involved. The HTA agency would be a better body to do it. The agency right now has no possibility to run its own research. However, the budget is fed with some money from the social security contributions. And I believe that the agency could work the following way. There is a call for proposals. A pilot project will be carried out in a specific area. And there are some requested medical devices and technologies to be studied by the agency from the public fund, and then you just choose the public network of cardiology hospitals or cancer hospitals. And I believe that some local hospitals should also be included. So 5-6 stages to be done and to be validated under the pilot project researched by the HTA agency. If we have green light for all 5 or 6 stages, the answer is quite simple. A new technology, a new service, a new benefit, ensuring better quality of care or better cost efficiency. Let's do it, but don't be short-sighted. And I believe that was the perspective often taken by the Ministry of Health. Because everybody asks, how much does it cost right now? The question should be reformulated. Are we going to afford that technology in 2 years, in 3 years? And I think we should include both the direct cost of the National Health Fund and indirect costs of absences at work, treatment costs, and so on. So once you have these findings, you can move on. And I think we need comparative studies. The new procedure, the new device, and the old one with a specific list of parameters. And again, I think that based on that finding, these types of findings, the decision should be automatic and should be positive, and the new device or service should be included in the guaranteed package. So the modernization of the guaranteed services package should be automatic, otherwise we will never catch up with the needs. You know, Monday is always a day of challenges at the ministry, and we start at 8 a.m. All the phones are ringing up because it's Monday. And with that approach, the ministry will not be able to define the pace of change and define the pace of modernization, and should only act as a regulator and sort of a budget manager. So, this is the key to the whole process. And my last point, I don't know whether it's good news, but I think it will calm the tensions. I hope Europe has been struggling with the issue of medical devices. At the health committee in Brussels last week, we had a discussion on MDR. And someone said MDR actually is not a success story in EPO, so in the European Patent Office. I don't want to be wrong, but there is like 80% or 70% of all the patents covering medical devices. That's the statistics. This is about patents, and now let us move to the implementation. There are only a dozen% of implementations, and the majority of implementations concern the US. So we make a registration at the EPO, and then these patents are implemented in the USA, and we are not implementation friendly, simply. We are not. And it's not about money. The investment money is there, but the path is uncertain. It's not long, but it's uncertain. There's so many issues which depend on the Ministry of Health as a decision maker. I see yet another risk, and that's confirmed by the European Commission for MDR. We want to make the certification requirements more strict. And that is why we have on the market the devices which are known, and the scope is quite restricted. And right now, these medical devices which are simple, known, and used for many years, and they now have to undergo a lengthy and time-consuming certification process. And because of that, the access to such simple medical devices becomes restricted. That's what is said by many EU member states. That is why also the Commission has promised to speed up work on a better innovation path, and that's one of the priorities of the new Health Commissioner. The MDR will most probably be changed in order to reduce the cost of certification for medical devices which are present on the market for quite a long time. Let me now move on to MDR. I think we've overlooked one thing in Poland. I believe that the agency makes its assessment and assumes that the new medical devices have no clinical studies. But that's not true. The MDR is quite restrictive. Europe and FDA actually introduced the requirement of the feasibility study and made the American requirements more restrictive. But Americans quickly realized that they made a mistake and changed their approach to feasibility study. Europe has failed to do so and fails to realize that the MDR is far too restrictive. So maybe it would be better to create a system, even for Polish businesses, to prepare for reimbursement processes in Poland, in Europe, and in the world. Well, the scientist comes up with something nice, and then there is a market test, there is a HTA test, and the product fails. The majority of startups I know have a lot of great ideas, and they actually have successes on other markets. They are in Poland, they fail. And hospitals actually fail to recognize which technology is better. And the only criterion of choice is cost. And I believe this is easily visible in laboratories. Don't forget that when you implement the innovation, there is a training offer. And some clinicists in Poland do not know the relevant path for certification and for the assessment of the innovation. And it's regrettable. Maybe the ministry should hear us more. But that's good that the ministry decided to take part in the debate on medical device. But automation, for instance, is an important criterion. And there are differences from one country to another. But let's just start with the most time-consuming things. We have GCA, we have new test options. We can also see how to organize the revision with a strict time framework. It's about timeliness. The agency has 250 staff. That's one of the largest HTA agencies in Europe. Are these resources used properly? And there are plenty of resources. CS is a case of in point. E-registration is a good example. It's a political topic, a hot topic. But if we have a pilot project, and the pilot project under the pilot project, there is a transfer of data between the IT system of the National Health Fund and the other IT system. We simply create an extra burden for the provider. A dealer is also created by the external provider, but I know that the features will be there to align the systems, and that's an ailment, that's a nuisance. The pilot projects are based on external databases, and they actually disappear once the project is over. Well, they can be used for research, but they cannot be used centrally, and that's a waste of time. Why the CS cannot create tools in cooperation with the National Health Fund or with the healthcare providers? Something is created under the pilot project, maybe it could be changed. And then you spend 1 million zlotys on a database, and the database is unused. Maybe we should work more on the standards of documentation for the HIS system. And we don't use this potential. I have a dream. I do have a dream that once we will have a meeting to talk about the key factors of better efficiency at the central level, and then the key factors of better accessibility. Is it the question of the provider or someone else? Well, patients may have certain applications, 10 applications, they all need to log into all the applications, and each application is used by a different provider. So the provider will build a telehealth application just to improve efficiency. And then you will have 10 providers with 10 applications, and it's not efficient at all. And this is a commercial third-party service. And then the patient has 5 systems, 5 applications. Is that what we want? I think that there will be plenty of difficulties. And I know that we are talking difficulties only, but that's good. But what is the goal? ABMCS and the agency and the Ministry of Health, what should be the role of each of these entities for accreditation? Well, accreditation means data. Accreditation means risk analysis. Who will analyze the risk? NHF? Maybe it should be revamped and redefine. I know it's not easy politically in terms of processes and people, especially that we are facing digitization and adaptation. But Poland is ready, and it's ready simply because we have needs. We are ready to speed up. And e-prescription is shown across Europe as an example of a speedy and swiftly implemented solution. Why not use the same approach in HIS system? And me? Okay.
Jeśli chodzi o przygotowanie takiej, czy przyjęcie takiej strategii i określenie celów, które mają
Well, the goals
elementy tego systemu regulowania
of specific components in the system should be defined. I do share your view, and this should have been done years ago. But don't forget about the political side of things. There are different visions, for instance, for health insurance contributions and how the money should be spent. The digitization in Poland is a scattered process, so you need to clean up. There are scattered applications used by hospitals, various solutions used for teleconsultations or for medical briefings. Some tools are used for coordinated care, and we have e-consilium in cardiology or in oncology. And right now we don't know how to adjust these solutions to the system. So I agree that we just add another IT system, and there are different HISs. We have no data warehouses. There are plenty of instruments that need to be integrated into HIS system. Otherwise, you have to transfer data manually, and thus it's not optimistic. ECOG, e-dealer needs to be integrated with the key system, the HIS system. And without data warehouses, the situation becomes complicated. Let's say we have one digital tool that follows up the patient, and then you need the stage of integration, and it takes time and it takes costs for the hospital. For cardiology, for instance, the money is not the problem. What is the problem is the IT staff. And the IT staff is missing, and they will need like 8 months to implement the integration. So we see the challenges, and we can talk about problems. I think it's a cathartic discussion, but be optimistic as well. IKP and the internet online patients account is a success. So there are stories of good solutions, pilot projects now. The pilot projects are not improving. I don't agree. They are repeating what the mistakes from the past. For instance, the Cardiology National Network had a pilot project. We wanted to check if this coordination gives some effects. It does. If there is a coordinator employed and paid extra money, the outcome is positive for the patient. If there is no coordinator of care, the patient will queue. It's true, some primary care facilities are not involved enough in coordination. And I believe that pilot projects are too often used to test things that are obvious. Just have a look. When you read the post-pilot project report, you see nothing new. It's more like putting the food into the door in order to then integrate the new device or service into the package. I've made the exact and very in-depth analysis of post-pilot project reports. And my conclusion is that the error is made at the very beginning, at the stage of planning. And National Health Fund is not the one to analyze data. They fail to analyze their own data. There should be one body which will decide who, when, and how will analyze the data. The data from the National Health Fund are not useful for all the metrics that we need. It's true, there has been an improvement, but without nuances. KSO. Just look in depth into the data, and I didn't see the findings from the National Cardiology Network. And why do we have so poor reports? Because we didn't plan properly what will be measured. And the National Health Fund will not be able to do that. And we do not know how the whole process went. And that's the goal of the pilot project. That is why the analysis, post-assessment analysis, post-project analysis should include the conclusions and recommendations on corrective measures regarding the course of the process and the reasons behind the failures. For instance, missing integration of data or lack of standardization of data, simply because we used 10 systems, underdeveloped, overdeveloped. And the question is why some would fail to adapt. I am told that for some hospitals the implementation of data systems was actually problematic. For instance, there are faults in the registration of pharmacology administered to patients. Well, it's problematic. A lot of problems in the systems, they are there, and the analysis is not thorough. The pilot project is about launching something new which requires the changes in communication training, data collection, process organization, and so on and so forth. Let's be honest. It's not just a one-off action. That's the regulator's view. That's the regulator's view. But on the hospital side, it's different. Actually, I have a meeting with the hospitals involved in the pilot project on National Cardiology Network. and I want to know them, want to hear them to see what failed and what was successful. And there will be a report issued by the National Health Fund, just figures, even negative figures, but without answers to the question why. And it would be interesting to know, maybe the key HIS system was not adapted to the integration of data from the pilot project. Well, just examples of causes behind such failures. And there is one more fault in the pilot project. And as we already have had so many pilot projects, we should learn. There are some faulty assumptions and faulty methods used to analyze what went well and what went wrong. Yes, so everything starts with the planning and the assumptions. The pilot project, it's the systemic HTA. What kind of intervention, what outcomes, what costs, what efficiency, and what management and infrastructure are needed. For that, we need indicators or other indicators. That's the type of assessment that is being done within the HTA. For now, we only analyze whether the pilot project worked or no. Think about the learning curve. We had first pilot projects in 2017. Yes, we always make mistakes. The question is about using the lessons learned. I think we need a critical mass to use systemic data and use those systemic data for some other evaluations. We have a nice from Spain in the room, and she will talk about the use of data in the next session. We need to have a multidisciplinary reflection on the data made available to us, and I want the HTA agency to be more proactive, to be less bureaucratic. I think it has already started, but we need a sort of a framework for that. Thank you. I know that you didn't have a chance to ask questions. I do hope that we are going to exchange during the lunch break, and you are invited, and you can talk to our guests. Do you still have power and energy? I've got a train in 15 minutes. Well, I do hope that we will have a chance to talk. Thank you very much for this fruitful conversation, and let's feel invited for the last session. We are going to talk about indicators and AI and the solutions adopted in Spain or in research, and RWE, how to use real-world evidence collected in the healthcare systems. Thank you.